So thank you, Patty, Ruth, Brenda, IOM, and Livestrong. I hope to provide some policy implications that you've requested. I realize that there won't be formal recommendations, as Patty has mentioned, to the IOM, but please engage in the workshop proceedings during and afterwards so those implications can rise further and faster. I will cover these 5 points. Here we go. The incidence trends of cancer in adolescents and young adults, 15 to 39 years of age, which was defined by the progress review process in 2005. So the age is usually 15 to 39, although for many reasons you also have to look within that range because it's so heterogeneous. The cancers are so different. A 15 to 19-year-old is so different than a 35 to 39-year-old. It's a very difficult task to cover a breadth of that age range. So be careful about what age group the speaker is addressing. In general, I will try to stray from that for specific highlights, but 15 to 39 is the intent. I will discuss the new problem, at least one that we hadn't recognized as fully, with regard to so-called non-invasive cancers of not malignant or definitively malignant behavior. That's usually judged by the pathologist, but that's turned out to be a larger part of the AYA problem than we previously recognized. If you're going to talk about incidence trends, you might as well also address death trends and survival along with it. And finally, an effect that I think we should all be appreciative of from the Patient Protection and Affordable Care Act. So incidence trends. 5 years ago in Nature, several of us, including Brandon at the table, Ronnie Barr, David Thomas, Chad Ellis, and Barry Anderson, heavily represented by the National Cancer Institute, published this review, which I recommend, not so much because I just told you who the authors are, but because this is a better piece than I realized when you go back and look at something and find, oh, I didn't remember that. Or, and at this age, that seems to be an increasing problem. However, notice right off the bat, if I can use a pointer or a, let's see, problem is there's 2 screens. So if you want to look at the pointer, I guess I got to go, or is there a pointer from the keyboard? And check this out. No, I don't see that. All right. Well, I'm not sure. Oh, maybe. Let's do this. Okay, so breast cancer, lymphoma, both Hodgkin and non-Hodgkin, melanoma, female genital tract, that's mainly cervix cancer, and if you want to add thyroid, account for more than half the cancers between the age of 15 and 40 in the United States. Since this is for both men and women, males and females, you can see that this portion would be twice, quarter of the total for females. And over here, testicular cancer, actually here at 7% of all the cases would be 14% if we just looked at males in this age group. So those are the predominant cancers. And this group, this array, this collection occurs at no other time in life. And I'll make this point once more. Pediatric oncologists and adult treating physicians, medical oncologists, hematologists take care of adult patients are not as familiar with this challenge, this group, as they are with all of their other patients who have very different cancers. So that was a need for biology, for epidemiology, and for practice consideration, including training, residency programs, fellowships. Now that we've noticed them, several specific fellowships in AYA oncology. I don't want you to worry too much about this. Go to the article in Nature or look at this when it's online. Let's look at just the right. This is the proportion of patients. So it's a proportion up to 16, 17, 18% with that cancer during the age group. And between 15 and 40, the AYA range, you see several cancers, over 9, 10 of them that have their peak in proportion of cancers in that age group right within the 15 to 39 interval. And you can look at those as bone sarcomas, other sarcomas, melanoma, cervix cancer, ovarian cancer, but here it's ovarian cancer of the stromal type, usually not carcinoma, non-epithelial cancers and mixed tumors of the ovary, testicular cancer, thyroid cancer, Hodgkin lymphoma, non-Hodgkin lymphoma, and Kaposi sarcoma, which is this black line, proportion up to 6-7% as of 2008. 2008 when this was published. So these are the cancers that predominate and make it such a unique challenge for physicians and allied health professionals caring for this age group. Here are new data that were prepared primarily for the September meeting of the National Cancer Institute scientific status of AY oncology. And I want you to look first at those colors. Anything that's orange or red is an increase. Oops. And if there's a very high increase, it's red, not so high, orange or light orange. And the value is for those with the highest increase. That will be the average annual percent change over the interval that's being assessed the last decade using SEER 18, which is 28% of the United States in this age group. Almost 30% of all persons now are in the SEER program. So this is as accurate as we can do in the United States, and I think these values stand on their own merit. If there's a decrease, it'll be green, and the darker the green, the greater the decrease, and the greatest decrease would be this darkest green. Again, the value inside that box will be the decrease, average annual percent reduction in that cancer over the last decade. So let's look at the data. The age groups represented here at the bottom are by 15-year intervals, less than 15, 15 to 30, 30 to 45, 50, so forth, to try to make the intervals comparable, 15-year intervals. You can also see that at the very top if you want to look at that. 15, 30, 45, 60, 75 are the breakpoints for this age evaluation. The outline in black is for AYAs. 15, now here again a slight difference in the age distribution because it didn't stop at 40, went to 45. So it's 15 to 45, but I broke up the AYAs into these 15-year intervals within the 15 to 45-year range. Notice, first of all, there's been no significant change for the vast majority of cancers. They're in white. There's no obvious trend, either of an increase or decrease. And this is something like 23 of the 26 cancers, of the 29 to 30 cancers represented here. But at the very top, you do see those that have significant increases. And in red, 5, 6, 7, even 8% per year increase from the previous year. These are extraordinary increases. Less red below that are cancers that are not with the numbers because they're between 2 and 3% or less than 2% increases. We'll come over these individual cancers in a minute. At the bottom, and they're ordered according to increase at the top and decrease toward the bottom, you do see some very significant decreases in cancers in AYAs. I'll just say 3.1% for cervix cancer, 4.9% for, at least in the older of the AYAs, per year on the average over those 10 years for lung cancer. Also melanoma, although it's not as rapidly decreasing and it's in the younger of the AYAs, those are the three most predominant decreases, and unfortunately there are only 3 compared with, 5 at the top? Thyroid cancer, kidney cancer, colorectal cancer, testicular cancer, and acute lymphoblastic leukemia. All have had statistically significant, sometimes extraordinary increases in incidence over that past decade from 2000 to 2010 in 15 to 45-year-olds, or at least depending on the interval 15 to 20, 30, and 30 to 45-year-olds. Notice that the most increased are thyroid and kidney cancer. Kidney cancer is only increasing at those rates in AYAs, whereas thyroid cancer is increasing in everybody, all ages, even children. We need to think about that. It's a much broader policy implication, and the overdiagnosis that's currently implicating, overdiagnosis, unnecessary treatment. And I'll have another point to say about that. Then we have underneath those two, obviously, our colorectal cancer is increasing, testicular carcinoma is increasing, at least the youngest men, and then ALL, acute lymphoblastic leukemia, was definitely increasing. It may have slowed down in the last part of this decade that I am referring to. We probably need to come back to the whys of these increases and decreases. But in the meantime, a couple of months ago, in Pediatrics, as an e-publication, was this report from the National Cancer Institute, Washington University, and Dana-Farber on melanoma. And I'll just read you one of their conclusions, that melanoma in children increased by an average of 2% per year, statistically significant. The only decrease referred to or noted by the authors was in the 15 to 19-year-olds. They stopped at 19, so I had to understand why the only age group that they noticed some decrease, and depended on the area of the country, high UV exposure and so forth, wasn't obvious in what we were looking at from 15 up to 30 or up to 45. So I redid the data from that publication of 2 months ago, now 3 months, I guess. And you do see that there was an increase in the first years of the last decade. So here we are, slight increase in melanoma among men and women between 15 and 25 years of age. Watch that. It's not the same as 15 to 30 or 15 to 19. And then a decrease, and that decrease was 2.7% per year on the average, and statistically significant. Because of the interest in melanoma of sex issue, females didn't have a statistically significant issue, but that's primarily because there were too few to evaluate. It's still about the same rate of decrease. Again, the trend similar in girls and males who did have a statistically significant increase. So I think there is a real decrease, that's what the SEER data from 28% of the country implies, in melanoma, as implied on the previous chart. So in summing up the incidence rate, thyroid and kidney cancer are dramatically decreasing in AYAs and older adults, although kidney cancer is increasing much more so in younger adults and adolescents than in any other age group. Thyroid cancer is also increasing, but in everybody, all ages, for diagnostic reasons, and we'll come back to that if you wish. Colorectal and testis carcinoma are also increasing in adults, but not as rapidly as either thyroid or kidney cancer. And ALL was increasing in and only in AYAs. Let me repeat that. Acute lymphoblastic leukemia has been increasing in the past 30 years, including the last decade, in and only in adolescents and young adults, and that's 15 to 39. Now, breast cancer, Patty's always made me think about breast cancer. It may be increasing in young AYAs during the past decade, and that's been reported in JAMA to be advanced cancer, meaning metastatic stage 4 disease, by Dr. Rebecca Johnson and Frank Chin about 3 months ago. So that increase is now known to be specifically metastatic disease and not early, not advanced breast cancer. And that's in AYAs, and again, only in AYAs, advanced breast cancer. Now, lung cancer has declined in older adolescents, as did melanoma, the carcinoma of the cervix in young AYAs, to cover all the increasing incidence. Why is that? Well, the good news for melanoma and lung cancer may have resulted, I didn't say increase, I should say declined. Oops, decreased. Decreased. That was at the bottom of that previous chart. I think I said increased. So the explanations are, for at least melanoma and lung cancer, that may have been because the national effort to reduce these cancers with screening and advice and education, prevention campaigns may have been successful. Lynn Reese points out it may be also because the state of California was added to the SEER program instead of just the metropolitan areas of San Francisco and Los Angeles basin. And because the state of California has had such an aggressive campaign against smoking statewide, that may have also helped understand why the decrease occurred. So I think these are indicative of programs that the Institute of Medicine and other national policy boards have advised and we've undertaken. So I think it's correlated with that effort. However, the dramatic increase in thyroid and kidney cancer is likely due to the ease of detection with ultrasound and other diagnostic imaging. And I think that implies that we're diagnosing more than we need to, and we're finding things that, as you probably heard, at autopsy, the number one common finding nowadays on the few autopsies that are being done is thyroid cancer. It's been there all along. The increase in colorectal carcinoma incidence may be due to HPV-associated rectal cancer, and that needs to be assessed. And along with that, the increased detection capabilities with colonoscopy that's being applied more widely. Those are guesses. I think the top bullet or two are not all that much speculative. So again, the question of increasing the incidence of these thyroid and renal neoplasms tumors, maybe not malignancy, raises the issue of overtreating our young adults and persons my age when that not necessarily needed to be. Cigarette smoking, well, that explains the decrease in lung cancer too, because as you notice, we've had a successful campaign, at least in the United States, of reducing not only smoking in adults in green, but students. And I think these were high school students since 1990. It went up and down, and that decrease has got to have something to do with decrease in lung cancer. In terms of sunscreen use and the prevention of melanoma, all these are only slight increases. They're said to be real increases, increased use of sunscreen. I think there are policy implications with regard to that for both males and females, whether they're 18 to 24 or over 24 years of age, as shown in this chart. And then also the indoor tanning device elimination or prohibition or reduction in use is shown here for all races, non-Hispanics, Hispanics, and Hispanic blacks and blacks, although not so much in the latter ethnic or race category. So I think we've accomplished something with regard to reducing melanoma. And then, of course, there's the 2 HPV vaccines that are now available and being used more broadly now, and also boys as well as girls, in early adolescence and in older age. And you see that in terms of trends for the vaccines, whether they got one immunization or all three. I think that helps explain some of the reduction in the HPV-related cancers, including hopefully colorectal, or at least rectal cancer, and oral cavity and oropharynx cancer. Since I've already, noticing the time, gone too long, I'm going to mention only one point about the non-invasive cancers. In preparing for that science of the state of the science meeting for September, a group of us with Ann Geiger, Ronnie Barr, and Lynn Reese, and others at the NCI and the SEER program, found this. This is a chart of the percentage of all cancer by age that is not considered malignant by the original or review pathologists. So let's go on the left and see what that means. Here in children less than 5, 2 to 5% of cancer in children, and it's rated as cancer, it's in the SEER program as cancer, are not malignant, at least according to the referring pathologist. These are usually benign, quote unquote, brain tumors. They do kill later, and then of course the pathologist will readdress that original diagnosis. But many of these benign brain tumors, they look so low-grade gliomas, but nonetheless kill. But the group that has the highest percentage of these non-invasive, quote, non-malignant cancers, according to the SEER program and the collection of data, are AYAs, and it's up to 15, 16%. And it goes up dramatically as we approach the 20s. It's stable across the 30s, and then there's this blip here, primarily due to screening mammography and the finding of localized carcinoma in situ, LCIS, and some ductal carcinoma in situ that accounts for that peak. So there's this strike peak, sudden peak, but everything else here is partially brain tumors, partially breast cancer with LCIS, and partially a variety of others. And I don't have time to go into that, but we have a new problem that we're calling cancer more likely not cancer in this AYH group, and yet in many cases, unfortunately, it access cancer and has a mortality rate. So we're looking into that. It's a 12 to 16% problem. 1 in every 6 to 7 to 8 at least. There we go. How many minutes? I can't read that. 2? Okay. So let's go to implications. I'm going to do this. Yeah, this is interesting, but we're going to leave that alone. The Affordable Care Act. And I derive the next few ideas from the data you didn't see. So you're going to have to go online or get your CD or stick, whatever we use. Okay, so if you go back to the original intent of the Affordable Care Act to raise the age out of insurance to 25, and you know what the White House and others published after the first 15 months of the Affordable Care Act, you'll see that these new insured 19-year-olds, 20-year-olds, 21-year-olds as a result of the Affordable Care Act. Total of 2,500,000 19 to 25-year-olds were insured when they hadn't previously been insured because the Affordable Care Act allowed them to be kept on their parents' insurance. If you then calculate as a function of time, starting with the first 15 months, this is now almost 2 years old, the number of new cases of cancer that occurred in these 2.5 million newly insured young people up to 25 years of age, this is again a year or two old, there would have been 4,155 new diagnoses of cancer among those 2.5 million. It all has to do with the rate and so forth of incidence. The probability then, let's see if we can, that since then, these are the data as of the end of this curve out to the second quarter of 2011, has continued to increase. So I tried to update this for us here. It was 2.5 million 2 years ago. It's now 6 million newly diagnosed, newly insured young people, 18 to 25 years of age. And if you look at the number of individuals who, since the Affordable Care Act was passed and this part of legislation was enacted, we have now almost 10,000 newly diagnosed cancer patients who were insured as opposed to not having been insured. And I think you may have heard of data that shows that the insured AYA patient has an earlier diagnosis and where potentially valuable, a lower stage in those cancers that can be diagnosed earlier. And that's been demonstrated by several, including the whole state of California, and an effort that I was involved with, Cancer 2012. Online, at least. I've forgotten when it was published. So here is the evidence that for the young adults, 26, that the insurance has helped them out. And I don't have time to show this to you, so I'm going to move on since my 2 minutes are up. Okay. So how can the IOM help? Increase awareness of favorable incidence trends. It can ditto, same thing, for unfavorable trends, as we've just reviewed. Promote clinical trial participation will help others address, and that there has been a favorable impact already on AYAs needs to be advertised, plugged, made more available to the general public. Advocate for the amendment and advocate for an amendment, because there's none in process that I'm aware of, that raises that age from 25 to 30 or 35, at least 35, if not 40. We shouldn't stop at 25, especially given the early data. And then, of course, others today in the Merle will address the issue of fertility preservation in this group. So I conclude that we need, let's see if I can do this way. All right, go back one more. That the AYAs have been in this hole, this gap, this chasm, and that we need to mind it, we need to mend it, and come to that meeting in September and hear more about this, especially what I wasn't able to cover. So what time have I got? -1? Ruth says, sit down. No questions until the end. All right, thank you. So let's move forward to